So I think I'll just share my slide and start the presentation. Yeah. So very good evening and very good morning to all of you, those who are listening us from across the world. We are from Translumina. I would like to invite everyone at this webinar, specifically called as the OPNNC Colloquium, where we discuss about the facets of OPNNC. So before we start, just a quick introduction about Translumina. What exactly is Translumina? How we are truly limitless, a company with solutions in coronary interventions that was incorporated in the year 2000, present in more than 70 countries, a great place to work, certified, four global manufacturing facilities, two indigenous manufacturing facilities, six strategic partnerships, and 10 years of clinical data with one of their premium stents. If I look at Translumina, we have an R&D excellence with German Heart Center and CE certified products. We recently acquired a company called Blue Medical, which has helped us to promote a product and manufacture a product called as the next generation DCB, which is Protege. And with OPNNC and Protege together, we today have a fantastic portfolio of crack and coat in hand. So be it in ISR, be it in different modalities, we today have a very strong portfolio of not only OPNNC, calcium modification, but also a lesion treatment tool, that is TCB. So just inviting everyone on this OPNNC colloquium, and now it's an opportunity for me to invite Dr. Sunil Thanvi. Sir is based out of Zydus Hospital, and Sir would be taking us through the entire agenda for today's evening. Just a quick introduction that he has been, instrumental in performing a lot of cardiac procedures across Gujarat, around 45,000 cardiac procedures, be it structural heart interventions, peripheral interventions. He's also a prolific researcher and published research in national and international journals. So, sir, I would now like to invite you to kindly, introduce our international faculty and chairperson. So, Dr. Thanvi, over to you. Sir, have you joined? So I think Sir has not joined. So Dr. Thanvi, are you there with us? Okay, no worries. So what I'll do is I'll quickly introduce our first speaker for the evening. So Dr. Giacomo Maria Cioffi, he's from Freiburg, Switzerland. Dr. Giacomo is an intervention cardiologist consultant at the University Hospital of Freiburg. He was the former trainee at McMaster University, Hamilton Health Sciences, and his special and main area of interest is intravascular imaging, stent failure, and chip and CTO cases. And Sir would be giving us his perspective on OPNNC, and he'll be talking about, a perspective that is guided with OCT. So, sir, over to you. And I would now like to invite you to just share your screen and start with the presentations.
Sure. Thank you very much for your kind introduction and welcome everybody. So to add on to your great presentation, I just to give you a small insight, I was at McMaster University in Canada, but I trained also in Switzerland where I got to really develop the skills with OPN since 2019. So I will present to you a case tonight, which is going to give us a good look at a very calcified lesions and its assessment. So and treatment. So it was a 77-year-old male patient who was known for dyslipidemia and hypertension. And he was already known because in November 2024, he had already an angiogram that demonstrated a severe multivessel disease. He was referred actually to Cabbage, but he refused that. And so he didn't get any intervention, any revascularization, and unfortunately he was lost to follow up. So we're skipping month and we're getting to April 2025, where I was on call during the day and I got the patient for an ACS type end stage. So I'm going to show you this is basically the first what I got to see initially. This the diagnostic angiogram. So you see a very calcified, most probably underfilled RCA, and you can see a very stenotic in multiple places, left system, left coronary systems with multiple critical stenosis and very calcified lesions. If I go cranial and cranial on the left side, you can appreciate the very calcified nature and multiple stenosis that this LED was presenting, with an aneurysmatic portion right at the bifurcation with the first diagonal branch, which is also a very important branch and divided in two subsequent branches, and it was also critical. So this is another view, and the spider view, that actually demonstrates that the circumflex is also diseased. Probably it's a little bit smaller than expected, and I think the RCA was way under Phi, and that was bigger than expected. But you can see on the left side the LAO cranial that the LAD disease is very diffused. So the LV angiogram showed the pretty much slightly reduced ejection fraction with this aneurysmatic akinesis of the inferior basal wall, but the anterior wall and the apex was still a little bit contracting, and the EDP was low. So here I would like to give you an insight of the possible approaches. I don't know if you want to try to answer via chat or just in your head to undergo what possible options are. And we can for sure try to upfront go for rotational atherectomy or intravascular lithotripsy upfront, or we can have a more safe approach and just go NC and then stent and DCB. There is also the possibility of going upfront with intracoronary imaging to understand better what's going on. I usually have in my head this algorithm, which is the Optima developed algorithm for severely calcified lesions. And if we proceed from the left side to the right side, where we have assess, modify, reassess, and stent, you can see on the bar up. If we take the first steps, we can see that the first thing that we have to do and see if we can image the lesion. So if it's an uncrossable lesion, of course we go upstairs and we go to rotablate. But if the lesion is somewhat crossable, then the first step is to image. And this is usually my approach, my usual approach, almost 100% of the time in such lesions. So OCT was no crossing, so we have an undeliverable OCT catheter, but the Sapphire semi-compliant balloon was actually crossing the lesion. So this is a mixed point where usually I can pretty much sense what the lesion is telling me, and usually with with a small profile balloon, I can get a good sense if I can get through the OCT catheter and have an image and see what's going on, or if I have to upgrade and go to rotablation. So here you have seen that the semi-compliant balloon was kind of doing some job, and then I upgraded to a non-compliant 2.0, which went to 16 atmospheres. But then you can see that while I was inflating more proximally, the balloon ruptured. So this is already another sign that the lesion is telling me that it's severely diseased. So of course, an image after this dilation to see if we had any perforation caused by the rupture balloon. And then I proceeded with OCT since there was no major complication. We can also see that the second diagonal is coming up a little bit down from the first diagonal branch. So I'm going to show you the OCT, which is, as expected, is going to tell us a quite obvious thing, but is going to tell us the two important things that we're going to see in some cross-sectional area. First thing first, we saw that, I don't know if you can see again, but we kind of see that the disease is very diffuse. We have already some cracks and some dissections of the vessels, and we have some healthy segment in between another lesion, most distally, that it's also severely diseased. So if we do some cross sections, and here I'm sorry I removed the angiogram and we're just going deeply in OCT, we kind of see here we are with the at the point of MLA. So if you remember, this was the point where our non-compliant 2.0 ruptured. So at this region of interest, we see a few things. So a little bit more distally, we see an eccentric with two calcium blocks that are very, very thick. So we have 1.1 millimeters of thickness. If we go a little bit proximal or a little bit before the MLA, we can see that the calcified lesion becomes concentric and still very thick, and it goes way more proximal to the LAD. If we go, so if we assess this plaque, we can see that is for more than 5 millimeters. So here we have almost 20 millimeters. The lesion is more than 180 degrees of arch calcified, and it's also thickened. So if we go further down the road, we see that, as I told you before, there was a segment that is a little bit healthy, where we can probably land our stent. And if we go a little bit more proximal than that, we start to see our concentric, very thick and calcified lesion. More proximal, this is the green cross section, is right before the aneurysm part. We can see that the lesion, the disease starts to become a little bit mixed. So we have some fibrotic tissue along with the calcific portion. So if we take back our algorithm, we see that we are here. We have to assess if we have any more additional vessel futures, which is, for example, the left main stem, an ostial RCA, which is not our case, some difficult bifurcation, tortuosity, or bending of the vessels, which is not our case. So we are on the green line because our lumen, if you recall, was actually more than 2 millimeters. So if we go down here, we can see that we are indeed in the portion of calcium angle more than 180 degrees, and the thickness plus the length. The algorithm would say shockwave. But, and this probably, being you from India, are even more sensitive than usually the more Western country. But if we take a look at the price of these devices, the changes and the difference is quite striking. So I take this algorithm as a feeling of what I should do, but since I'm a little bit I'm a little bit attentive also of the cost, I can see that at the price of one IVL, I can almost use 6 OPNs. So my approach is an escalating approach. And as you saw, I use the NC, and then my next approach would be to use OPN. So if we go back and take a look at my references, I can see, as we saw before, that the lumen is actually 214, and the EL, so the healthy vessel, is 290. So we could kind of be safe here to implant a 275 stent. But if we go a little bit more to the plaque, to the calcified plaque, we see that we have a lumen that reduces to 174 and even less with a 112. So while choosing your OPN devices, usually what we would say, and also the other experts worldwide would say, is that you take your reference and you downgrade for a 0.5 ratio for the diameter choice. So in this case, I chose to start with an OPN 2.015. And if your eyes are a little bit attentive, you can see that in the LAD, you suddenly see 2 wires. And we'll explain why 2 wires, at least in my experience, are very important. So I proceeded with a 2.015 to dilate, and it was actually delivering very good, up to 40 atmospheres. And the lesion was quite good expanding. More proximally, I decided, as you saw in the cross section of the OCT, I chose a 2.5, 15, where I went really progressively. This is not the first inflation. I usually go progressively up. I start with 20, 25, and I try to feel with the indiflator what the lesion is giving me as a feedback. So progressively going up to 40, 45 in this case. And then of course, you do your puff check, you assess if you don't have any perforation, any complication. In this case, you see already OCT pullback. So then you assess what you've done with your device and plaque modification. And remember, in this case, we use 2 OPNs, so we are at 1,200 euros. So if you take a look now at the second pullback, which is after plaque modification, we're going to see a lot of good stuff, which is actually what we want to see. We see dissections, we see plaque fracture, we see calcium fracture almost everywhere. So we start again with our cross section. This is our landing zone that was previously assessed, which is fine, is not anywhere damaged or injured. If we go more proximal, you can start to see that we have some very good fractures of the calcium, most probably along the whole plane. Of course, we have some very big and deep dissections, and these are medial dissections. We're going to come back to the dissection later. Then, if we go more proximally, almost to the MLA that we had before, we have a lot of fracture. We can quantify almost more than 2 per cross section. So we have steadily 2 or more fractures of calcium throughout the treated segment. And here more proximally, we are in the, if you remember, the zone of interest that we had before. We have our site of MLA that you can see it's still recoiling. So we dissected, and you can see here the plane of dissection. We have the fractures because we see it everywhere. You saw it before in the cross section, and we see it proximally. They're very deep dissections. There are almost 1 millimeter of fractures. And even then, this portion of the plaque is still collapsing. More proximally, we see again 2 nice fractures of the calcium and some gain of the lumen. So because of this, unfortunately, it's not the situation where we could probably use a DCB only strategy because the lesion is collapsing again. And this is actually screaming out about having some radial strength and giving back some structure to the vessel. So actually what I decided was to go from our safety landing zone with a 2.528 stent, which was the science, and then which was expanding optimally, and then place a more proximal stent, which landed into the left main, because if you remember, we had right at the bifurcation some very bad fibrocalcific disease. I implanted very good expansion and opening. And then I proceeded with my post-dilatations and stent optimization. We had all the information that we need with our second pullback run and also the first pullback run of OCT. So I pot in different projections. The stent was good expanding. We had the first check from the caudal view, which was giving a good image. And then I proceeded to post-dilate the second portion of the stent with a normal non-compliant balloon. And this is actually our result after stenting the lesion. So you can see that the diagonal is still open. The second diagonal is a very small vessel. We left it there. And so then as you can see here, I decided what I'm going to do for the second half of the LAD. I'm not a full metal jacket person. I don't like it. I think I gave the patient the most possible good outcomes for the future in the first portion of the vessels of the big LAD. And then I said, okay, if I get a good result and we can see right at the outro of the stent, we have some very good lumen, even though we have dissections. Remember, we still have to treat this portion more distally of the vessels. And if it gets a good result, we might probably stick with the DCB approach. So an hybrid approach with 2 stents and DCB down to the LED. So I started again with a semi-compliant, again, progressively going to 12 atmospheres. There was some dog boning that you can see right at the dot. And so I decided, okay, I have already an OPN 2.0, and I did exactly that. I went inside there and I did several progressive again inflations to get the lumen that I need. So you can see that the OPN 2.0 was expanding very nicely and was achieving the lumen. Of course, we can argue that here I have a lot of dissections. We can see it pretty clearly, but there is no contrast staining. The flow is good. I said the patient will need RCA treatment, SIRT treatment, diagonal treatment down the road. Let's try to preserve as much of this vessel as possible. And so I went on and I said, let's treat with DCB the whole second part of the LED. And I used 3 solutions balloon. So there are sirolimus coated balloons that I spread throughout the LED. And then I did an OCT to assess the result of the stents that I previously implanted. And we're going to take a look now. So remember, I haven't done any OCT run. I post-dilated my lesions. I knew my sizes, and this is the final OCT run. Of course, you can see now distally, the vessels is really, really dismantled and destroyed. So let's take a look at the first part. The stent is super nicely expanded. We can see a relative expansion of 96%. We can see an MSA of 4.7 millimeters square, so we're good. And we can see that we don't have any malapposition of the stent that we planted. If we go on the contrary down distally, we can see that we have all our dissections planes along with the fractures. And this, though, if you see here, the lumen is quite encouraging. So we have a good lumen, we have good deep dissections, we have treated the vessels with DCB down there. It's full. I cannot show you every cross section, but it's full of dissection due to the OPN. And this was probably the most brutal dissection that we had. And then if we come more proximally inside the stent struts, we can see how our fractures of the calcium due to the OPN now are expanding due to the expansion of the stents. So you can literally see how we achieve expansion, and we can achieve that by the fractures caused by the OPN. And so this was the final pictures. Of course, I know probably you're looking at this. There is dissection, profoundly dissected vessels, and these dissection projections. And then I said, okay, I'm gonna stop the procedure. We treated the most important vessels of his heart. We're going to bring him back for treatment of the RCA and the diagonal branch. And then, since he's coming back, we're going to see the result. So he came back for the stage procedure 3 months later to recover after the rehabilitation, cardiac rehabilitation. And as I told you, we had stage PCI to the RCA and the first diagonal branch. So this is the result. I will try to be short. This is RCA, and you can see that actually it was a big vessel, big territory, big myocardium. And this was actually the result of our previous work that you saw. So of course, there is some recoil here, but the vessel is way different than we had it before. The lumen is good, the flow is good. Is it gonna recollapse? Maybe, we will see. And we went on and treated the diagonal. And since we said we treated half of the LED with DCB, we're gonna treat also the diagonal with DCB. And you can see here on the right side, the result, the before and after the treatment. And then we finished the procedure. So a few words on the OPN. So I don't know if every one of you worked with OPN, but it's a special balloon. So he can go to high pressure because of a very unique design. So he has 2 walls of balloons. This is actually providing 2 things. First, the uniform expansion. And second thing is going to provide a less risk of dog boning and also a less risk of perforation of rupture of the balloon. Sorry. So by this technology of having twin walls, they can actually achieve a very good non-compliancy. So you can see here on the chart that even if we keep inflating the balloon stays almost continuously to the chosen diameter. So that's why it's also important to take a measure down of your balloon and up your pressure, because here is actually where the balloon is going to work and where you're going to achieve the cracks. And probably some of you have seen that I went way higher than expected. This is actually the recommended maximal pressure due to performance in vitro during the research and development of the balloon. So you can see that this is the zone, the rose one is the zone of safety margin, and all the balloons actually perform quite well above pressures that you see on the left side. But the rated pressure, the advised recommended pressure is 35 atmospheres. But you see that with my 2.0 and 2.5, where I was at 45, 50 atmosphere, I was well on safety. And as I told you before, you saw during the whole procedure that I had 2 wires in the LED. And this comes mainly from experience, but recently also some papers came out about the friction that using this high pressure balloon actually provides, and the stress that provides on the balloon inside and to the wire itself. So usually what I do is I take 2 wires. So I don't know if your worker wise is a BMW, if is a Cyan Blue, is a Grand Slam, you name it, whatever it is. What I usually do is what I take a lifeline. So I take a second guide wire, usually a atraumatic wire. So in this example, a BMW, where also, if you can see the chart, is the one that has less friction, less potential guide wire friction due to the retrieval of the used balloons. And I used this wire as a working wire. It should be sticking to the balloon. I have my workhorse wire in place, which is gonna stick there, and I'm not gonna lose my vessel. So this is usually how I work, and it's probably the most important tips I can give you is about using 2 wires, or as we call it, a pipeline or lifeline wire. On the right side, you can see the compatibility while using a guide extension. You saw it, was a very calcified lesion. It was not a nodular lesion, but it was a very calcified lesion. And I haven't used a single guide extension. I used a simple 6 French guiding catheter with an EBU 375, and then my 2 wires. So this was as simple as it get. And if you need to use a guide wire, a guide extension, please remember that there is an incompatibility with some diameters of the OPN balloon. So be aware of that. And in case you need it, you have to up your catheter guiding and use instead a 7 French guiding catheter, and that's it. So this was it from my side. I hope was enjoyable, was good. I don't know if you have any question regarding the intervention or you want to see some further imagings.
I think, sir, that was a very lucid talk. So I would now also invite our chairperson for the evening, Dr. Puneet Verma. Sir, if you're there online, so we can have some question, starting from you. And we also have Dr. Pranay Jain and Dr. Veena ma'am, and obviously Dr. Ledulak has joined. So any questions from the faculty members, if anybody would like to ask?
Thank you, Dr. Giacomo. It's very good case with OPN to preparation listen before we placement stenting. It's a very good case. And I have a question. Is the role of OPN balloon after placement stent when stenting is not advancing?
Sorry, I want to be sure I got right your question. So you say the role of OPN in expanding the stent after I place my stent?
Yes.
So
OPN,
yeah,
NC. Yeah.
yeah. So my main message would be since I'm an imaging guy and I'm also a DCB guy because almost 50% of my procedure are purely DCBs. But my main message would be do it right before you implant. So if you can use your imaging, you name it, IVUS, OCT, you name it, do everything you can before placing your stent. But then again, OPN is a very, as we saw with the non-compliant stable, is a very, very stable balloons. So of course, if you encounter, and all of us had those interventions where the place stent then had a little bit of recoil or was a little bit dog boning, but OPN can very, very be helpful in this kind of situation. I would always go half size smaller and up my pressure. So go high with your pressure, but choose a smaller balloon. This would be my take-home message in these cases.
And what pressure, maximum pressure, we can inflame in OPNNC? In your case, I see you inflame in OPNNC is more than 45 atmosphere. But
So in my
in
case,
OPN recommend it's less than 40 atmosphere.
yes. So I would say I've been using OPN since 2019 and a lot, really a lot. So with time and with getting to know the balloon, and if you apply those small steps like downsizing the size and upsizing the pressure, if you stick to those rules with time, the interventional cardiologist is going to develop his feeling on the balloon and he's going to be able to upsize the pressure. My take is if you're starting or if you're fresh to the OPN balloon, just go to the rated and recommended bursting pressure, so 35 atmospheres. Don't go beyond, because if you, for example, haven't used your OCT or your intracoronary imaging assessment, and by any chance you chose a one-to-one balloon, and you have by any chance a nodule or a calcific nodule, and you're gonna upsize the pressure, then you're gonna perforate. So this is what is gonna happen. So you need to slowly develop your skills and slowly develop your also what the indiflator is gonna give you as a feedback while inflating. But at first, I would go to recommended pressure.
Yeah. And you have indicate rupture coronary because of OPN and high pressure.
Only one.
Especially in the cancer noodle, I very afraid rupture coronary when I use
I
OPN in
had
very high blood pressure.
only one.
Yeah.
And it was a calcified nodule. I implanted the stent. I did OCT, and the result was not bad, but it was. I unfortunately pushed it. I was responsible. I mean, the result was not that bad, and as we know, perfection can be the enemy of good. And I tried to achieve perfection, and of course, as we know, disaster occurred, and it was a big perforation. But again, this was my take-home message from that case. The patient is alive, is doing well. I talked to him, but the fault was mine, saying that I went a size up of the balloon because I wanted that perfection to obtain that perfection that actually was detrimental and was catastrophic in the end. So yeah, I had, but only two. I think once perforation, big perforation. The second one was something minor.
Yeah.
I
Okay,
don't
thank you,
count
doctor.
I don't count dissections as complications. Dissections are what actually I want to achieve usually, but yeah.
So
Thank you,
I
doctor.
think we'll have some more questions from the faculty as we go ahead, Dr. Giacomo. But I think very nicely explained the importance of sizing. I think that becomes very important, and using OPNNC as a pre-dilatation tool. I think it is very important to be using it probably before putting in the stent, whether it is a nodule or whether it is a And obviously, when it is image guided, it becomes slightly easier, to size it properly. Right, it does. So next we move on to Dr. Ledulak from Vietnam. Sir has been, instrumental in establishing cardiovascular practice in Ho Chi Minh City, and he's associated with the cardiovascular resuscitation department at Thudo City. I hope I'm pronouncing it correctly, sir. So, welcome to, explain to us about the concept of lesion preparation and how today, DCB can be a complementary therapy in such case, right? So, over to you, sir, and thank you so much for your presence.
Okay, let me see.
Yes, sir. You can start, sir.
Okay, you can see my slide.
So we can see your slide. Earlier, we were able to see the full screen. Can you just unshare it? Yeah.
Okay. Good evening, my colleague. Thank you, Dr. Giacomo from Switzerland, with your presentation.
Sir, we are
And
we are actually not able to see the complete slideshow. Can you go to display settings? Can you just click on display settings? Yeah, on top. On top, it is written display settings. Just here, yeah.
it's okay.
No, no, no. It's still not okay. Just escape. Just write escape. So just unshare the screen. I'll project it from my end.
Let me see.
Yeah, now it's okay. Now it's okay. Perfect.
Okay,
We can start now.
it's okay.
Yes, sir, it is okay. We can start. Yeah.
Okay. Okay, good evening, my colleague. It's a great honor for me to join this distinguished panel to be a part of today's insightful session on lesion preparation on drug-coated balloon synergy. I am Dr. Lê Duy Lạc from Thủ Đức City Hospital, Ho Chi Minh City, Vietnam. I'm truly delighted to have this opportunity to share some talk and clinical experience. Uh, a hybrid approach in complete PCI candidate and DCB be complementary a clinical report. I will be focused on both strategy and practical considering. Thank you once again, and let's get right into the topic. And this is a K report patient information, male 67 years old, admit hospital with chest pain, past medical history tied to diabetes, hypertension, and stenting circumflex and RCA 10 years ago. Blood test is troponin T so high, anti-protein B and creatinine is mildly increased. In LDL cholesterol is not well management, and blood sugar is control is so good. Echography is good AF and reasonable motion abnormality, hypocalcemia, and the upper and anterior wall. And you can see the EKG during chest pain episode, horizontal at the depression precordial list. And the clinical finding patient alert considered heart rate and blood pressure in normal range, cardiac rhythm regular, and treatment aspirin, rosuvastatin, and empagliflozin, ramipril. Diagnosis: high risk non-STEMI, hypertension, type 2 diabetes mellitus, and history stent in Asia and circumvent 10 years ago. Management plan, medical therapy, and coronary angiography to evaluate indication for revascularization. And this is a coronary angiography. In this case, you can see a left main 70% stenosis, distal left main 111, and LAD severe calcification, and 90% stenosis, proximal LAD and circumflex, 80% stenosis in proximal circumflex, and especially in-stent restenosis, stent circumflex is 70%. And Asia, 80% stenosis, middle Asia. And I syntax score is so high, 48 points. Guideline recommend CIBZ is a good choice for the patient. This is a patient with left main and 3 vessel DC with a high syntax score, and patient and his relative refuse CIBZ. And which strategy do you choose? We can choose the PCI stent complete region from the Otium LID, or crossover stenting technique from left main LID, or DCB, the side brain and main brain, and two stent technique, or we can choose a hybrid strategy in the PCI, in the left main LID stenting and DCB circumflex. I choose a hybrid strategy for in this patient. Clinical zero DCB in the coronary priority. We indicate DCB in in-stent restenosis is recommend 1A, and some case we can use a dot cutting balloon for the de novo lesion and hybrid risk patient, and a QMI, bifurcation, and small vessel disease. Identifying the problem in stent restenosis. What is in-stent restenosis? Luminal renarrowing is more than 50% due to restenosis within stent, occur 10 to 15% of PCAK despite advance in that technology. At risk, Roscoe in-stent restenosis because of mechanical in-stent restenosis or biological. In clinical impact, reintervention increase the healthcare cost and work outcome. In-stent restenosis may be attributed to variable degree of influence of 3 categories of the factor in the stenting coronary arteries: extra-stent factor, stent relay factor, and intra-stent factor. We can see in this slide. And a possible step-by-step approach for the DCB only strategy is the first step: suitable ability for the DCB. The patient with multiple metallic stent implanted concerns about long-term presence of metallic stent, as young adult, as suspected metal allergy, etc., and high pregnant risk. And angiographic condition with the in-stent restenosis is class 1A recommend is small vessel DC, otium lesion, and bifurcation, and some case calcification lesion not expanded to be well expanded for stent. And the second step, optimal lesion preparation before using DCB. In my opinion, it is the most important step. Predilation with the NC balloon or cutting or scoring balloon are recommended. Balloon to artery ratio 1:1. Intracoronary imaging guiding is encouraged. If moderate to severe calcification is evident, we can say the rotablator or atherotomy or lithotripsy should be considered. And 3-step assessment after predilation to be confirmed the TIMI grade 3 follow angiographic residual stenosis less than 30% and absence of major dissection tipsy to help in angiography or medical involvement or hematoma detected in vivant or OCT, and absent in finding suggested of thrombus. If all the above criteria are okay, we can choose a DCB approach is suitable. and otherwise we can change to stenting placement strategy. And the DCB by treatment approach for coronary artery disease, we remember DCB to vessel ratio 1:1, rapid delivery, nominal pressure in the more than 60 second inflamm duration. Back to my clinical case, I performed the IVERT on circumflex, and I was in circumflex instant restenosis with MSA just 3.2 millimeter square. Instant restenosis mechanism due to stent under expansion and neoantima hyperplasia. And we can see one lesion 5 millimeter from otium circumflex mid-density lesion, superficial calcification with at less than 180 degree, MLA just 3.8 millimeter square, plaque burden 71%, and mean distal reference 3.3 and mean proximal reference 3.6 millimeter. And this is a parameter measured by IVERT on circumflex. We can see again, it's a de novo lesion with the MLA is very small with MLA just 2.8 millimeter square. And after that, I did IVERT on left main LRD. In the distal left main, the mid lesion superficial calcification with 180 degree to 217 degree. MLA 4.7 millimeter square and plaque burden 71, and proximal left main reference is 4.7 millimeter. And proximal LID IVERT saw superficial calcification with 180 degree and 272 degree, and MLA just only 2.2 millimeter square, and distal reference LID is 3.1 millimeter. And this is the parameter measured by IVERT and LRD. We can see the calcification is more than 180 degree. And now I modify plaque by using cutting balloon and NC balloon. The first time I use a fork NC balloon at 2.5 and inflam 20 atmosphere to left main and circumflex fork NC also in the high pressure. And after that, I use cutting balloon for in this patient. I choose a warfarin 2.1 inflam in 10 to 14 atmosphere in the side brain and the main brain, and also left main also. And this is a coronary angiography port modifying plaque by cutting and NC balloon. After preparation, the lesion we can see in the angiotemic ray, 3 follow in the LD and circumflex also. Angiographic in circumflex no residual stenosis, and LD have dissection to facilitate stent placement after. And IVERT in circumflex port modifying plaque by cutting and NC balloon. We can see the lesion proximal circumflex MLR improve from 2.8 millimeter square to 6.3 millimeter square, and plaque burden reduced. And IVERT in left main LD port modifying plaque by cutting and NC balloon. We can see the coronary calcification well resetted by NC and cutting balloon to optimize stent placement. And I choose the DCB paclitaxel in de novo lesion in circumflex and instant restenosis in circumflex. I choose protege balloon because of paclitaxel is applied within the balloon fork ensure minimum drug slot during transition, and quoting paclitaxel is applied over PCP quoting with elute the paclitaxel only when pressure applied. Eventually, multiple rod release technology up to 3 times made it easy to intervene for the both de novo lesion and stenosis lesion, like in this my case, helping to save the cord and the shorten the procedure time. I choose a protege and see a protege balloon size 3.0 millimeter inflamed the first time in de novo proximal circumflex at 18 atmosphere lesion and hold on the 60 second and inflame the second time instant restenosis. Instant restenosis circumflex 10 atmosphere and hold 1 minute. This is a angiography after I DCB paclitaxel. And with Lapman LRD, I choose a crossover stantin, crossover circumflex, and that Lapman LRD is a synergy stantin 3.0 stent placement into the Lapman LRD. After we place stent, I put dilation with fork NC balloon 3.5 in the proximal LRD and the POT Lapman with fork NC 4.5 millimeter. And check over circumflex, we can see the optimal result. MLA in de novo lesion, proximal circumflex is 8.3 millimeter square, and optimum circumflex with good MLA and instant restenosis is good stand apposition optimal stand in expansion after we pair patient in NC balloon and paclitaxel DCB. And check divert in Lapman to middle LID, optimal stanting expansion and minimum stand area in LID is more than 9 millimeter square, and especially Lapman MSA 14 millimeter square, and good stand apposition and no significant gap between stand truth and the virtual world, and full lesson cover rates both stand at fully cover disease segment with no residual plaque. We can see again the parameter I measure in the left-man area after placement stanting crossover. This is the final coronary angiography result at the final TB3 follow and the good angiography result. Thank you very much for your attention. I hope the insights shared today will be useful in your daily practice. I also look forward to learning from the upcoming discussion and hearing your valuable opinion. Thank you once again, and I welcome any question or comment. Thank you.
Thank you so much, sir, for your insights on lesion preparation. Sir, I think before we move to the next, I think there is one question regarding OPN on our chat box. So just quickly, just asking the question, Dr. Veena had asked that does changing the contrast to saline ratio affect balloon expansion? So Dr. Giacomo, I think you have already answered it. Any of the other speakers or our Dr. Puneet Verma, I think, is this something which we experience with OPN usually? Hi, Dr. Puneet Verma, sir. Welcome. I
Yeah,
think finally we can
yeah.
see
Hi.
you.
Sorry, I got stuck in a real bad traffic jam, but en route I got the opportunity to see both cases. Both were great cases, and I just wanted to comment on the first one also that it's a very good learning tip given by Dr. Giacomo about the use of two wires technique in OPN, especially when you are preparing the lesion. And it's not only acts as a cutting wire, but also helps to protect the lesion and your vessel, especially if you get burst OPN, or alternatively, if your OPN gets stuck on the wire. So that's one very good learning point, I thought, which of late we've been also practicing this for the last almost a year or so, when we had one or two episodes where we thought we would we couldn't retrieve the balloon, and we had to retrieve it along with the wire. So that was one great teaching point. The other, of course, is Dr. Dulac's presentation right now uh, on the use of OPN, wherein you see the two differences between contrasting presentations in terms of imaging. And in one, we have relied heavily on OCT, which I think in our country is still gaining momentum. It's not really picked up that well, so especially vis-a-vis the intravascular ultrasound imaging. So I think it's also important to realize the kind of lesions you see, the morphology on intravascular ultrasound, which also, especially with respect to the depth of calcium and the thickness of calcium, which we always believe is the thickness especially is easily measurable by OCT more better than by the intravascular ultrasound. So these are some points which I thought are worth mentioning, and great two cases.
Yes, sir. So you have
One
a question? Yeah,
is
Dr.
there
Dulak.
that when we are using a second wire and we are going at very high pressure of 40 atmosphere or 38 atmosphere, it is acting as a cutting balloon. But as we say, once we are using a normal cutting balloon like Wolverine or Angiosculpt, the pressure, if we are going to 20, that is at least double that of the, because it has multiple blades or wires. So the pressure which is, you are at that transducer is showing 20, but it is around 40. So if you are using a Copian NC at 40 atmosphere with a wire, can that increase the pressure applied to the vessel wall?
Uh, it's no, I wouldn't agree on that. I would only say that it only acts, it gives you an interface. The wire acts as a further interface between the balloon and the intima. And therefore, the pressure which is applied by the OPN would be actually the same, be it a double membrane balloon. It really that is one of the methodologies in its manufacturing to make it as non-compliant as possible. As we see that there is hardly any dog boning seen in when you go in for OPN inflations at high pressures. So what the point I made was that that just the second wire sometimes gives you this collateral benefit of acting as a part cutting in that particular segment of the or particular sector of the artery as you see it cross sectionally, depending on if the wire biases towards the lesion or not. Otherwise, its basic role of a second wire would always be protective, lest if you're OPN, you're not able to remove it off the wire.
So usually my
So,
practice is that to just go at high pressure with OPN, and while removing OPN, just before removing, I say wire with a second wire. Then I usually remove, because most of the time it, because of friction, it attaches to the wire. Usually Grand Slam and all, it does not pick up much, but other normal coating wire, if you are using, it definitely sticks to the wire, and if you are pulling out the balloon, the wire also comes out. So
so
before,
two great wires, I would think, would be the run through and BMW, which either of you could keep as your workhorse wire, and the other one could work as a support wire. Uh, of, of course, the
I think, sir,
more
Dr. Giacomo
hydrophilic
actually
the
shared a
wire,
slide
greater
for
are
this.
the
Yeah.
chances that the would actually stick on you.
so in
Sorry?
that slide also, the 5 wires which were shown were mostly cyan blue extra
Yes.
floppy, the BMW, Grand Slam. These were the 3 major wires which he also was using.
Yeah, in my personal case
So I think
and my
I
personal
recall he mentioned
experience.
about a Grand Slam.
No, sorry, go on. You hear me?
Yeah, we can hear you, sir. Yeah, please.
Okay. So in my personal opinion and experience, I think that Dr. Punet is very right. I would use one of the low friction wires as your working wire. So in my cases, I never had a problem with BMW. Sometimes you had some batches of BMWs that you get delivered that are a little bit different from the other wires, but this happens. This is a manufacturing standard deviation error from the manufacturing. I mean, it's normal. But what I usually do is just put my, you name it, Grand Slam, Scion extra support, whatever you're using as a as the main backup rail for giving support and giving structure. Whereas the BMW or your low friction wire acts as the rail on which you use your OPN balloon. This is what I have in my head as a working algorithm. So I need more support. Okay, I'm gonna go up front, put, I don't know, an extra support, a Grand Slam. Then I'm gonna put my BMW that it's gonna rely as a rail for back and forth, back and forth. And the case that I showed you, I mean, I haven't put every angio that I did, but the inflations were probably, I don't know, 60, 70 inflations, totally the complex of the procedure. So I usually love to go to up my pressure slowly, see how the vessels reacts, and work slowly up to the point that the lesion is open and it's cracked. And then what I need, you don't need many puff, many contrast, many check with your angios. You're just gonna do your puff to see if you have any catastrophic results. But then it's just OCT, and you have your only image, and then you have all the data you need, and then you're gonna work as it is.
Right. Dr. Ledulak has raised his hand, I think, for quite some time now. Sir, you had a question? Yeah.
I no question.
Okay, okay. So I think pretty good points being discussed about OPNNC, and I think especially the wire point. So I would now request Dr. Veena ma'am. She's joining us from the prestigious Jayadeva Institute from Mysore, and ma'am would be presenting a challenging case which in which OPNNC was used, and it helped the patient uh, probably being rescued, or OPN came to the rescue. I think that would be the right way to put it. So, ma'am, over to you, and thank you so much for gracing the occasion.
Thank you, Ritesh. A very good day to everyone. Those two were excellent presentations. And probably this case will be a summation of the learning points of what Dr. Kiyofi mentioned. So what we had 47-year-old gentleman presenting with evolved inferior MI. He had coronary artery disease with a single vessel disease, significant right coronary artery disease. If you can observe his angiogram, there was a calcific mid to distal RCA disease. So our plan was an upright rotablation approach. We were not considering imaging early on because the IVUS catheter was not getting past the lesion. So the plan was to do a upfront rotablation, image, then probably optimize the bed with either cutting or scoring balloon modification. This was what our initial approach was. We did a rotablation of with a 1.5 millimeter bar of 160 to 170,000 RPMs. And this was the IVUS pullback image. We can see that there are about 270 to 360 degree calcium in multiple areas, especially in that mid-distal RCA bend. And what you can also observe is the reverberation rings. And as we know, the more the reverberation rings on IVUS, it suggests that we are dealing with probably a deeper calcium. So we went ahead with the lesion modification further after rotablation. So this was a check angiogram after rota. The polishing rounds of 1.5 mm burr seemed promising enough to stop at this point of time. We did not upsize the burr. So then we went ahead with a cutting balloon, a 275-ton Wolverine at about 16 atmospheric pressure. And these were the balloon dilatations. We mostly work under fluoroscopy because of it's a high volume center. So we do not take cine stent images or the balloon images at every given point of time. But the expansion and boost the sites on fluorostort seemed promising. And most of these balloons were delivered with the help of a 6 French guide extension catheter. We were using a telescope. And since there was damping of pressures on a deep engagement of the guide, we had floated a wire in the aorta. So we also further optimized with the 358 NC balloon because as per the IVUS image, the sizing of the vessel was about 4 millimeter in RC and the distal was 3.5 millimeter. So this is how it looked like. And we can see that this is the area which had some amount of 360-degree calcium as well as a nodule here. So what we did miss during the whole scheme of things was this particular dent, which you can see here, which we retrospectively reviewed it. And after this phase, we went ahead with stenting. So we delivered a 3.5 tapering to a 3 millimeter Biomime Morph 50 millimeter drug-eluting stent. It's a particular Indian make stent where the balloon tapers from a 3.5 to 3. And we thought that is ideal for landing it at a distal pre-bifurcation region. And there was no problem in delivering the stent. So we deployed this is when our trouble started. We deployed the stent at 16 atmospheric pressure, and we can see this dent which continued to persist. So now we were dealing with an unexpanded stent. This is how it looked like on stent enhancement. So we then proceeded to take a 3.5/10 OPN. All the while we had taken a 7 French guide catheter, but a 6 French telescope. We did not have a 7 French guide extension. So when we attempted to use a 3.5/10 OPN to the point of interest of lesion unexpanded segment, what we noticed was this OPN was getting stuck at the distal port of the guide extension itself. So we removed the guide extension. We did not know at that point of time that the 3.5 was not compatible with the 6 French guide extension. So we reintroduced with preloading of this 3.5/10 OPN outside. And factually, it went outside and we preloaded this 3.5/10 OPN outside and then took it in. But we could not cross the lesion. On trying to retrieve the balloon, though it was not utilized, it was not expanded, it got jammed onto the run-through wire. We were using a workhorse run-through, and we had to remove the entire system in total. So now we have a vessel with a stent and an unexpanded segment within the stent. We recannulated, rewired with 2 buddy wires. That is, we totally had 3 wires in situ. However, we still could not negotiate the OPN through this. This time around, we were trying it directly without using a guide extension. We removed 1 wire. Kissing balloon was tried with a non-compliant balloon. 2 non-compliant balloons at that particular segment site. Again, it did not work. Why we attempted all these maneuvers was simply because it's a patient-paying market in India. So we had already opened an expensive balloon. So we tried all maneuvers to make the 3.5 OPN to ease through the lesion. So we could easily ease the 4.5 NC balloons through the lesion. It was just that bulky nature of the OPN could not negotiate itself into the lesion. Then the balloon anchoring method was also tried. This frame is showing that we had anchored the 1 more balloon on the distal segment, and we were trying to ease the OPN. It did show some promise. It inched to the proximal edge of the lesion, but it did not cross the lesion. We then attempted to go with a 4.8 NC and multiple dilatations, and then we even went with a 4.5/6 with minimal dilatations, and it seemed promising again. And this was how it was at the end of it. So the lesion was unyielding. So after this, we took in a second 3.10 OPN because we had exhausted all our techniques and maneuvers of making the first one work. So 3.10 easily walked through it, and it did cross the lesion. And this was the 3.10 balloon OPN at 35 atmospheric pressures. And at 45 atmospheric pressure, it satisfyingly gave way. So the next immediate response for us was to do a check angiogram to make sure there was no spicule-related coronary perforation. This was the check CAG which was done. And since the vessel was a 4O at that particular point of sight, we re-optimized with a 4NC balloon at that site. And we repeated in IVUS, and we got a MLA of about 11.4 in the proximal aspect and approximately about 9.5 and 9.5 in the mid-endostal segment. So we could complete the procedure with Timiflow and reasonably good results. The word on the calcium, which tends to get deposited at the bench, the arc of calcium here is small, and the necrotic core, which develops here, tends to rupture more. And these are the sites for nodules and initially eruptive, which can present as ACS, and subsequently, after stabilization, we see more of the protrusive nodules here, and flanked by large arcs of collagen calcification. This is what we usually see at bends, and especially the RCA, which is prone for it. It's an excellent paper which I came across. And another thing was, though our rotablation showed promising with respect to the polish runs, what our rota had done was, since we were using a rota floppy wire, it was hugging to the greater curvature. And if you could see the dent later, it was more on the lesser curvature. So our rota had not touched the inner curvature calcium at all. And maybe a rota support wire could have changed the cutting approach of the burr, but we did not have a rota support at that particular point of time. The two things which we did not have, a 7 French guide extension catheter and a rota support wire, maybe that would have made a difference to our technical difficulties later on. So further on, we always, any ship case, we always use a 7 French guide extension catheter. And I think this is what we discussed. And this table post after this case has been a go-to format to make sure that anything that is more than 3.5 does not go through a 6 French guide extension catheter of OPN. So we should always use a 7 French guide extension catheters. And how to deal with post-stenting and expanded stent, prevent it. IVL could have been used, but financial constraints were the problem. OPN 3.5:1:1 was getting stuck at the distal port. Triple was were tried, KB was tried. We were contemplating even focal reablation of stent with larger burr if the second OPN did not cross or did not yield, but fortuitously it did. And second focal stent inside, we were not comfortable in case that suffered a similar fate. A take-home message, wire buys, especially in RCA, may not ablate the calcium along the lesser curvature. So we have to keep in mind. And maybe repeated imaging at every step would probably give us that idea that we are working with a less prepared bed. In our case, rotablation was done with a 1.5 burr. The plan was to modify with cut and open OPN. Lithotripsy was not considered because of finances. Post-IVUS testing of the lesion with balloon dilatation seemed promising. Hence, we went ahead with the stenting. How this case has changed my practice? Like I said, we always go with a 7 French guide extension for any chip cases and after this case. And imaging must not be limited to only post-debulking, but also used before stenting to confirm the lesion modification. Thank you.
Thank you so much, ma'am. So, any questions? I think Dr. Giacomo has raised his hand. Sir, please.
Yeah, beautiful case, Dr. Vina. Congrats. I mean, lots of good points. I mean, amazing case. I think we don't have so much time, but there would be a lot to talk about. I think your case beautifully explains and shows up many of the tips and tricks of not only of the balloon, but also of the procedure PCI in very calcified lesion itself. So as you beautifully said, I mean, the imaging, the IVUS showed clearly, to me at least, that there was a nodule indeed. The distal cross-section showed that you already had very beautiful fracture and dissection. So there was at 5 o'clock, 4 o'clock, there was already some separation of the plaque with beautiful separation. But before that, there was indeed some very bad nodule, and as you pointed out, again of note, you mentioned it and you used it. I think that the telescope is a nice guide extension. Speaking of which, probably I don't know if any of you have access, but the new liquid guide extension is a very promising because it has a inner diameter which is a little bit larger. It could be a nice device to have on the shelf in these kind of cases. Another thing that probably I didn't mention in my presentation, but this is the perfect example case that Dr. Vina showed us. So sometimes, I mean, I'm in Switzerland, I can open many balloons, but I usually I think about the finances as well. And what I learned through the years is that sometimes even your 3-5 balloons, if you preserve the metallic stylet and the plastic sheet and you don't throw it away, you can very, very nicely reshape your balloon. What I usually do is I take a plastic sheet of another balloon, like a 3.0 or even something smaller than the balloon I used, or one of the plastic sheet that is a little bit more thick, like the one that you use with a stand or with a 4.0 balloon. And I replace the OPN on the stylet, go inside the plastic sheet again, and then I will usually do some inflation up to maximally use it, usually 6, 8, maximally 10 atmospheres, and back and forth, back and forth. This usually gives back the shape to the balloon. And I would say it works 95% of the times to recross lesions. So in this case is exemplary, like you were able to take a new open balloon and it was able to cross. So it was the shape of the balloon itself. I don't know if many of you tried, but try this reshaping technique. If you have the guide liner, you can do it, the guide extension, you can do it inside the guide extension. You just retract it inside and then you inflate 6, 7, 10 times. Take your time, but go 6, 8, 10 atmosphere, negative, 6, 8 atmosphere, negative. Do it multiple times. And this usually helps a lot. More than wires, more than guide extension. Believe me, it reshapes the balloon. If it doesn't go, just extract everything, use your stylet and plastic sheet, reshape the balloon, and go back in. But this was a very good point, which probably could have saved you the second device. Probably. We will never have the confirmation. And then I think you did a beautiful, beautiful explanation about the calcified nodule and the wire bias of rotablation. Beautifully said. I think I agree on all those aspects. So congrats and thank you.
Thank you so much.
Uh, Sir, Dr. Puneet, any comments from you, sir? Anything from your side for case, or should we move to the next presentation?
Yeah, I think we can move on. I think Dr. Giacomo has very well summed it up. And,
Perfect.
wonderful
So,
case, Dr. Veena. Congratulations. Very well done. Yeah.
Thank you so much, Dr. Veena. So we'll now move to Dr. Tapan Kumar. Sir, if you can just share your screen and switch on the video. We'll move to the next case of the evening. I think Dr. Tapan Kumar, sir, you're there? I think I'll just call him. In the meanwhile, we can start with Dr. Pranay Jain sir's case if sir is there with us. Dr. Pranay Jain sir, can we start with your case? In the meanwhile, we get in touch with Dr. Tapan Kumar. Is my voice audible? I'm just thinking nobody is listening.
Yes, we're nice and clear.
Oh, that's okay. So I think Dr. Tapan Kumar and Dr. Pranay, I'll just get in touch with Dr. Pranay Gore sir. If you are there, we can start with
I
your
can
case
start. I
first.
can start.
Okay,
Sorry.
I'll share.
Ajay, Dr. Pranay sir is there. Okay, so we'll start with Dr. Pranay Jain sir. Okay, okay. Now Dr. Pranay sir is there. Okay, yeah. So you can share the slide. So, Dr. Pranay Jain, sir, is joining us from the central part of the country. I think sir is associated with the Care Hospital in Raipur, and he'll be presenting his case on the multimodality approach, rota plus cutting plus OPN in subtotal calcific instant restenosis. Sir, over to you. Thank you.
Good evening. Thank you for this opportunity. So this was a 72-year male. He is able.
Sir, your slides are moving. Your slides are moving.
I am not able to see here. 1 second. Something.
But we are able to see the slide. So you're on the second, I think on the case slide. You can just push the escape button. Just try and push the escape button and then share it again.
1 second. So now my slides are moving.
Yeah, perfect. Perfect, sir. They are moving now. Yes. You're on the second slide. Yeah.
72-year male. He is diabetic, hypertensive, and dyslipidemia, and no addiction. So he underwent PTCA with stent to RCA in 1999. Now came back to me with exertional angina and dyspnea for last 3 months. So echo was done, which was severe LV systolic dysfunction with severe global hypokinesia, mild MRTR with mild PAH. So this was the left-sided system. So proximal LAD and diagonal was having some lesion. Proximal circumflex was having lesion. And this was the RCA. So you can see this, I think this was some old Texas stent or something was there. I don't remember now, but 2-point markers are seen on that stent. And there was subtotally occluded vessel. And severe calcification can be seen inside the stent. So most likely it is a neointimal calcification, which was the cause of atherosclerosis, associated atherosclerosis. So wired directly, and even with 0.75 into 6 LVHP, I could not cross. So I tried multiple time with even guide extension. I could not cross with 0.75 into 6 LVHP, 0.85 into 6 Nick Nano also. So then I tried directly wiring with rotafloppy because microcatheter was not crossing, and just wired directly with rotafloppy. So 1.5 bar at 1,60,000 did not cross for 2 minutes. I upscaled it to 180 RPM. And after 2 minute time with 180 RPM, I was able to cross the lesion. So post rota, I went up with 2.5 into 10 Wolverine. My usual practice is whenever I am doing rota, I go up with cutting balloon Wolverine at high atmosphere, 16, 18, 20 atmosphere, followed by NC balloon. So this was the result post rota cutting and all. So stent position with guide plus 2 guide extension catheter. So you can see that the position, still that the old stent portion, still I am having the residual. So this slide, if you can see, still the residual is present at the old stent, this thing. So I again went up with 3.5 into 10 OPN, and at 32 atmosphere, the stent opened up well. So this was the final result. Split 5% residual at that old stent position, but TIMI 3 flow, no edge dissections, stent opened up well. This was also, again, I have done 4 potency also. And this was the result for the LAD and diagonal. So LAD I have stented, diagonal I have just did a cutting balloon followed by DEB. So you can see a linear dissection there, but post DEB there was TIMI 3 flow and the vessel was flowing, and there was no flow limiting dissection. So I left it alone after DEB.
Hi, sir. So, any questions from anyone? Dr. Giacomo and Dr. Puneet, sir, any questions from your side?
Any
And,
imaging
Dr.
you did, Dr. Pranay?
Yes, sir.
No imaging was done in this.
So at that time, I was not having the imaging at that. Now we have an OCT console in our lab along with IVUS also. But this case was done, I think, 2-3 years back. At that time, I was not having the imaging at center.
And it was an old stent, right? The previous
It
one in
was
the
a
RC.
1999 stent. I think this might be Texas or some old stent, sir, with the 2 markers in that. And that was calcific neoatherosclerosis because nothing was going. Even with guide plus 2 support, 0.75 LVHP and 0.85 Nick Nano, I could not cross on the Grand Slam wire. So then I changed it with directly, I've added it with rotafloppy, and then I did rota and cutting, and then lastly OPN was required. And for LED and diagonal, one stent strategy with DEB to diagonal.
And you used a 1.5 burr large vessel. Did you consider a step burr approach also? I mean, did you think you could go a step, one step higher on the burr before?
My
in
usual practice, I don't step up the burr to 1.75 or 2. I usually use a burr, then cutting balloon. If required, I keep always 3, 3.5, 2.5, all OPNs in my lab ready.
Okay.
Dr. Giacomo, anything from your side?
Well, it aligns with Dr. Punet's comment. I mean, I would have used, you heard me, I would have used imaging, but again, Dr. Pranay actually told us the cause why he didn't use the imaging. But yeah, no other comments. I mean, it looks very good result, and yeah.
Thank you.
Right. So I think we'll move to the next presentation now. Dr. Tapan Kumar, sir, are you there now? Available with us? Dr. Tapan, sir, can you hear us? So I think Dr. Tapan is, sir, is there any issue? So I'll ask my team to just get in touch with them. Dr. Pranay, can you, Dr. Pranay Gore, sir, can you just share your slide?
Sure.
Yeah. So, Dr. Pranay Gore joins us from the southern part of India. I think sir is based out of Sunshine Hospital, Hyderabad, and he has more than 10 years of experience in ACS, preventive cardiology, and currently he's practicing at Kim's Sunshine Hospital. So, sir, over to you for your case presentation, specifically talking about OPN and under expanded stents. Yeah, thank
So
you.
my slides are
Over to you, sir.
visible.
Yes, sir, slides are.
Okay, so I have three cases to share. So if it is getting late, just let me know. I'll finish with the first case first. So it's basically the story of OPNNC where we got stuck with the underexpanded stents. So what is OPNNC to us is basically we all have been uh, uh, we all know that it has established an efficacy in ISR and complex PCI. Why? Because of the because of the technology which it holds. It's a super high pressure balloon with a twin wall balloon design. So the first case is a 62-year-old male who is a hypertensive diabetic, comes to us with chest pain on exertion for past 10 days and dyspnea on exertion. So it's a chronic coronary syndrome, now reached a stage where he's pretty symptomatic. So we took him up for angiogram. So the left injection shows there is a proximal LED critical lesion, and we can see there is a tram track calcification over there. LCX also seems to be diseased, and with the calcification of the LCX2. So it's a heavily calcified left system, and the right system is calcified, but doesn't seem to be very critical. So all three vessels calcified, heavy calcification on angiogram only. So uh, what I did is the imaging modality first, and then decide the therapy based on that. So this is the OCT run of the patient, where we can see that there is dense calcification from the mid part of the LED till the proximal part of the LED. And in the proximal part of the LED, we can see it's a 360 arc of calcification. This is the positive remodeling which we can see, and then suddenly the lumen gets narrow. Yeah, so that is what is the area of interest. So the lumen was 0.91 mm square, which is the tightest part of the area of interest, and the LED ostium was 7.49, and the just beyond the lesion it is 10.34 mm square. So it is just a short area where we need to focus more. So that is the reason my first choice was I would go by a balloon based therapy. I took an IVL 3 into 12 and delivered 80 pulses there, and followed by IVL. I did a NC balloon dilatation at 18 atmosphere, but the waste did not go away. So we can still see that the waste is there. And after doing IVL, I acquired the OCT again, and I'll focus more on the place where the lesion is not yielded. The lesion is still tight after doing IVL, 80 pulses, and NC balloon. So the strategy has not worked here. So what I did is I tried to debulk the lesion. I took a rotablation 1.5 mm burr and tried to rotablate it with multiple runs. So initially there was some resistance, and then the burr crossed, and it was a free movement, and till the mid part of the LED I have shaved it and then acquired an OCT again to see what has been done. So this is an across length of the LED. So the entire vessel is calcified, but the lumen appears good. There are some areas where there is some narrowing, but I did not focus more on that. So my main interest was only the proximal part of the LED. So yeah, so lumen appears to be much broader after the rotablation and dilating it with the balloon. So then after knowing that the lesion is well prepared, I took a 3.5 into 18 mm Zine CR and deployed it at 12 ATM. So after deployment there, we can see still there is some dent at the mid part of the stent, and I tried to go ahead with 3.5 NC balloon because the vessel dimension was around 4 mm. So 3.5 into 12 NC balloon was dilated till 24 atmosphere, and this is the angiogram which we can show. So can we accept this based on the angiogram? So let us see what the OCT tells us. So this is the OCT picture doing post stenting. So again the run. So the stent has started, stent has expanded in the distal part, okay. But as we come proximally, the stent appears to be under expanded. So there is a gross under expansion of this. So this is the proximal part of the stent has a good luminal gain, and the mid part is highly under expanded, 2.67 millimeters square. So that needs to be addressed. So the option remain here is OPNNC balloon for me. So I took an OPNNC balloon. So this is the first inflation of the OPNNC balloon at 30 atmosphere. We can still see the dog boning in the 30 atmosphere, and then when I go to 35 atmosphere, the dog boning is gone. The stent has expanded nicely, and at the check angio also shows the stent is evenly expanded. And this is the OCT final OCT picture after doing an OPNNC balloon. So we can see that the lumen has become irregular, but it has given up nicely, and we've got a good luminal gain here. So what the upper portion shows us the post pre OPNNC balloon use, the under expansion, and once we've used the OPNNC, the mid part of the stent has gone till 7.3 mm square. That is almost twice, almost more than 2.5 times. So that is what the OPNNC has helped us, and this was the final result. There is a good expansion of the stent, and then the L6 was also treated with rotablation and stented with a 33 mm stent. So this was the end of first case. So if time permits, I'll go to another two cases and I'll finish that shortly, or if it is okay, then I'll stop it here.
Sir, we can go ahead with the other cases. We
Yeah.
still have around 4 minutes to go. Yeah.
Yeah. So the second case is a 62-year-old male who is a hypertension diabetic, and underwent PTCA in 2007, now admitted with chest pain. So he's got a triple vessel disease. So that is what is his angiogram. So that is the LED. There is a tight lesion in the mid part of the LED. Right coronary appears to be good, and the circumflex there is disease. So the vessel which I'm going to show is the LED was tackled before, and then the vessel which I'm going to show is only the LCX. So LCX was wired initially, pre-dilated with 210 balloon, and we can see clearly that there is dog boning on this thing. So this was a heavily calcified vessel. So the IVL was taken here. 2.5 into 12, and we delivered 80 pulses for this, but still we can see there is some dog boning with the IVL balloon. But on angiogram, we can see that there is some gain on that. So after the IVL, we did an NC balloon with 2.75 into 12, and then after knowing that we've got some expansion and modification, I stented it with 2.75 into 26 onyx. So after stenting again, the mid part of the stent has not yielded and the under expansion is noted there. So we initially post dilated it with 3 into 15 NC balloon, and then the check angio again done shows that no, it is grossly under expanded, it's not yielding. And there again the OPN comes into the play. So now we have downsized the vessel again back to, I stented with 2.75. The open NC balloon who used here is 2.5 into 10. And we slowly went up to 40 atmosphere, and then the stent has expanded nicely. And then proximal part was stented. So that is what is the final result. So the stent is evenly expanded, the vessel looks good, TIMI3 flow, no complication. And third case is an acute coronary syndrome case. So he comes with inferior wall MI. He was given loading with dual antiplatelets, atorvastatin, and was started on cannular infusion because he was naive on antiplatelets, and shifted to cath lab for PCI. So the LCX was cut off here, and in the middle image in the epicranial view, we can see there is a calcium speck in the LCX, which can be noted there. So LCX, as it was a culprit lesion, it was wired, pre-dilated, initially with Ryuri, then 2.5 cutting, and then stented with 2.5 to 33 alpine. Stent expansion, everything looks good in this picture. TIMI3 flow was established, patient was shifted to cath lab. From cath lab to ICU, and then 3 hours later, patient again landed up with chest pain, ECG showing STT changes. We brought him back again, and then we took a check angio, and we see that the stent is thrombosed. So we wired, created some space, and established the flow in the LCX vessel, and then we acquired an OCT. So now the OCT tells us there is a gross under expansion of the stent. The proximal edge, if we see the proximal and the distal MSAs, it is only the mid part is half of the diameter. So that is the reason the patient landed up having stent thrombosis. So now what was the option was initially dilating that with the guide plus. We introduced the OPNNC balloon in, dilated it, multiple dilation going from 20, 25, 30, 35 to 40. And then this is what we've achieved. So the MSS have improved now. And then again, after doing the OPN NC, we took a normal NC balloon and then went up with the high pressure and established the flow. And then this is what is the MSS what we achieve in the mid part. Initially we were 2.2 mm square, and after doing the OPN and high pressure NC balloon again, we achieved till 6.6 mm square, 6.6, 8, 6 and 7 mm square. And that is how we gave the patient a good result. So angiographically, it doesn't make a hell lot of a difference. But OCT wise, we understood that no, what we did was wrong. And this is how the imaging has solved the problem. So this was the third case. So I keep the thing open for discussion now.
Thank you so much, sir, for explaining the range of cases of OPNNC. So, Dr. Giacomo and Dr. Puneet, sir, anything from your side on the cases? Yeah.
Yeah. Thank you. All good cases, but there are some learning points in these. And I would think that whenever we aim for lesion preparation prior to implantation of a stent, even if you have to go in for a balloon, for a lithotripsy balloon, I think primary use of a lithotripsy balloon upfront should not be the case. You should first try to prepare the lesion before putting in a lithotripsy balloon, even if it means pre-dilating with a NC balloon, a 2.5, and then thinking about, because the aim of a lithotripsy balloon is not to break the waist. Uh, well, of course, if it does that, because your inflation pressures are just 3, 5, 4, 6, maybe 5, 7. You have the sequence you followed was lithotripsy, first case, rota, then a stent under expansion, and then an opium.
Yeah, I actually dilated it first with the NC balloon, sir, 2.5 NC, and then
Yeah.
got an OCT, and then went ahead with IVL. It did not debulk, for debulking I used Rota, and then again NC, and then OPN NC.
Your rotablation, I think, followed the IVL, right?
No, sir. IVL was first, then
That's
Rota.
what I'm
The
sorry.
other way around. Yeah.
I'm sorry if that was the way it was shown. I thought you probably used IVL as a primary balloon, which looked because
No,
there
sir.
was
I
a lot of
initially
dog burning
prepared
on the
it. It was
IVL.
not very critical that did not allow the OCT catheter to enter first. So I dilated, then only I took an image to see what exactly we're dealing with.
Okay.
Yeah.
Fine. Because in your circumflex case, also the one which you did also, we saw a similar thing. IVL, the waste did not really come out well. You implanted the stent, and then you've all shown where OPN has been used for post dilatation of stents, right? Uh, as we rightly understand, yes, that's also one of the utilities of an OPN balloon. But as Dr. Giacomo has also shown in his presentations, that if you use OPN for pre-stent bed preparation, maybe you get better hang of and you can maybe cut down on devices as well. Good cases. Thank you.
Yes, thank you.
Anything from you, Dr. Giacomo? Or should we move ahead to the next presentation?
I agree with Dr. Punet, and especially I don't know very well the Indian system, but I know that for you the cost is most of the time a priority. So I would say you opened up an IVL, you could have used 6, 7, I don't know your price, but in my country I could open 6 OPNs before opening an IVL. So my
It's the
guess
same,
you
sir.
also use those. It's the same. Okay,
It's the
perfect.
same, practically the
So,
same.
It is
so
absolutely same.
I would say even if you use, let's say, 3 OPN balloons, still you're down the cost to half of it. So you did perfectly, and you did OCT. It showed you that most probably, like it showed you a lot of fibrosis before the probable cap that was behind the big chunk of calcium. So you showed it nicely, and I believe you could have tested it, and then who knows, maybe it opened up. That's at least my approach. So my algorithm in my head is NC OPN. If that fails, even at 45 atmospheres, then I'll open up the IVL. And again, in my head, again, it's a personal feeling. Rotablation is not a plaque modification tool; is a facilitator. I always say this, and this is what I've also been taught in Canada. Like, remember, rotablation gets you quicker, but it doesn't modify your plaque. It just helps you go faster to the result, but you're gonna need some plaque modification tools afterwards. It just simplifies your workflow and streamline of getting there. So again, I agree with Dr. Punet. I would have gone with an OPN probably first by this wasting, and then take it from there, and then maybe open up the IVL. Why not? A short comment on the ACS case. That was really, really interesting, and probably shows how sometimes is more a comment on the lesion, on the plaque itself. I don't know if you agree, but sometimes the circ calcification are monstrous. Like, we don't expect the result is good, and then bam, it makes recoil our stent, and then we're puzzled because the patient comes back and the stent is all crumpled up. Like in your case, yes, probably was a little bit of under expansion, probably, but I guess most probably was a strong recoil because probably of that plaque big chunk of calcium that you saw in the the cranial, in the cranial view, in the AP cranial view. You really showed that big chunk of calcium that probably just pushed again in the hours that follow your stent. So again, we come to the lesion preparation, but in ACS, I always take it carefully because it's an ACS, so it's a STEMI. We need to work in a different environment and mindset. But this is probably a very most probably the most informative case from a plaque perspective. Very interesting.
Right. So, thank you, Dr. Pranay Gore, sir. I think very interesting insights, especially coming in from those multiple cases, and we could say a lot of use case for OPN and C being there. Let's have Dr. Tapan Kumar now from TMH Hospital, Jamshedpur. So, sir has been a clinician associated with TMH Hospital in eastern part of the country, and he would be presenting an OPN case presentation now, which is the final for the evening. So, Dr. Tapan, if you could just share your slides, yeah.
Good evening. Nice discussion. Very good presentations. All presentations are very good. So let me to start my presentations. So thank you for giving me this opportunity to speak in front of such a good gathering. So my case was a patient with a very critical left main with severely calcified LAD. So he was an 85-year-old male, 84 year, has a history of diabetes and hypertension from almost 15 to 20 years. And there was history of chest heaviness on exertional activity for last 2 to 3 months, which was increased from last 50 days. And then when we did his ECG, which showed there was some non-specific STT changes, and unfortunately his echo also showed normal LV functions with no regional valve motion abnormality. Initially, considering his age, we thought that we can continue with the medical management, don't want to do any intervention considering his age. But even after 1 or 2 days of the treatment, his symptoms were almost there. He was complaining of pain on routine activities. So we thought at least do some angiography for him. So this was his angiogram. You can see the caudal and cranial view. There was critical disease in the ostial left main, almost 80 to 90%. We failed to engage the guide into the left main. And whenever we are engaging, there was a severe damping of the blood pressures, and the proximal part and the mid part of LAD was severely calcified with critical disease. There was also some disease in the LCX, but it was not significant, which was appearing from the images. And then there was also 60% disease in the OM. So we thought we'll not do anything to those other vessels. And then there was also disease in the RCA. I am not showing the RCA, but that was quite stentable. So as there was a critical left main disease, we thought we have to do something this patient. So it was a case of unstable angina, severely calcified coronaries with left main and triple vessel disease. When he calculated the syntax score, it was 28. So we discussed the patients with for the revascularization option. So they immediately denied for CABG considering his age. That was quite obvious. He was around almost 50 to 60 kg body weight. So then we discussed with the party, and then we decided to go for multi-vessel PCI. So as for our plan, we thought of upfront rotablations because the lesions were severely calcified. So we wired the vessels. We kept one wire in the LCX, OM, and then one in the sinus. As whenever we are engaging, this was 7 French guide from the femoral root, and then we did the wiring of the LAD left. So because there was significant damping, we are forced to put one wire in the sinus. And then this was, so initially we thought that we will do IVAS, but IVAS catheter was not crossing even the proximal part of the LAD because left main, because of calcification. So next was we thought that we'll do some rotablation. So this was I just missed one picture because rotablation was not crossing the left main ostium. So what we did, we just took around 2 mm balloon and dilated the initial part, ostial left main, just to facilitate the crossing of the rota. And you can see there was a so significant lesion in the at the level of diagonal that even rota was not crossing. So after several attempts, we failed to pass the rota when we increase the burst speed to more than 170-80 revolution per minute. And after successful rotablation, we thought that now we can do the rest of the things comfortably. But this with the floppy wire exchange with the rotawire, we removed the rotawire and then we took again the floppy wires. So see this so much calcified. We tried with the different type of predilatations balloons. This was NC balloon initially. The larger balloon was not going inside, so we took around 2.2 into 10 balloon, and then we took around 3.5 into 10 NC balloon. And then you can see it was not giving away. There was a lot of residual uh, yeah, lesions. So it was not opening at all with the NC balloon. So we did balloon up the whole of the lesion. So proximal and mid LED were not at all opening with the NC balloon. Yes, and then, but fortunately the left main was opened well with the NC balloon. So this was the time we thought whether we should take a IVL or we should take a OPN balloon. Now we took around 3.5 into 20 OPN balloon. We did multiple predilatation, and at last you can see how beautifully this lesions open with the OPN balloon. So we don't have any problem with the OPN balloon. We went ahead up to 35 to 40 atmospheric pressure, distally up to 35, and then proximally up to 35 atmospheric pressures. And then our job was not difficult. We stented the distal portion with the 3 into 48 millimeter stent. This was the cranial view, you can see. And then initially we post dilated whole of the stents quite nicely with 3.5 distally and then 4 into 12 NC balloon proximally. And then we have to put the stent for the left main and the proximal most part of the LED. We took around 4 into 28 millimeter drug-eluting stent. These are the different view, just to sure that we are covering the ostium well. So these are the different view you can see. So we covered that ostium quite well, and after that we dilated again the LED left main with 4 into 12 NC balloons. And this was the angiographic picture. Here we again took the IVUS, but in IVUS we saw that there was an area of malapposition in the proximal and the left main stented part of the proximal LED and the left main. So we took again 4.5 into 8 millimeter balloon, and it was post dilated image. And this was the cine image. Just we saw how the stent has opened, and these are the final results. So we can see there was a very good result in the proximal and the this is the caudal and cranial view. So after this was the final result. So as per our planning, everything went well. Rotablation definitely, as you told, it facilitated because initially even 1.5 millimeter balloon was not crossing. After doing rotablation, everything crossed quite comfortably. And then we did rota, and then we did NC balloon, and finally there is very good result with the OPN. So this was the end of my case. This was the final picture. So can you hear me?
Yes, sir. We can hear you, sir. Yeah.
Okay.
So,
So any comment?
any questions, Dr. Giacomo, Dr. Ledulak, Dr. Puneet, sir, any questions?
Very, very nice case. Indeed, very nice. And as we saw, what I was saying before, probably as a comment, that the rotablation here was a facilitator, was not modifying the plaque. So indeed, you achieved the modification of the plaque indeed with the OPN. I don't know, maybe you've done it, but you haven't showed it. Have you done an IVUS run after the OPN and before the
Yes,
stent implantation?
yes, sir. Yes, sir. I did multiple time of OPN,
Okay,
and
I
after
missed it then. Sorry.
yes, sir.
Sorry, my bad.
Okay, sir. We did it.
A beautiful case. No, very nice.
Okay, thank you.
Right. So I think this was the last presentation. So any parting comments from the faculty? I think we can start with Dr. Giacomo. Sir, anything from your side, the session, and then Dr. Puneet and Dr. Ledulak sir can further end the
Well,
session.
thank you very much again for the opportunity. I think that the main take-home message that we have to take from this presentation is that there are pitfalls with using OPN, and we need to be aware of them. So sticky wires, non-deliverability, maybe helping us if you are new to the platform, to the OPN platform, helping us out with the use of intravascular imaging, size correctly your device, because again, it's an NC balloon, but it can be a very disruptive device if we don't know exactly what we're doing. So this is, if you're new to the OPN, use intravascular imaging for the first tens of cases, 20, 50 cases, adapt yourself, measure it nicely, assess before implanting the stent. Probably this is also a very good point, like reassess every time you use the device. Have I achieved the fractures? I've achieved good plaque modification before implanting the stents, because we saw you can expand nicely the stent, the under expanded stent, the dog bone stent. But again, if that doesn't work and IVL doesn't work, it means that you have to ablate acutely a fresh stent, and this can be destructive. So again, lots of tips and tricks, very, very nice cases. And from my end, thank you very much.
Dr. Puneet sir, from your side.
Yeah, very much. I agree with Dr. Giacomo. It's the decision to use. I mean, angioplasty is all about prioritizing your pre-dilatation, how you prepare your bed, vascular bed. I think that's most important. And whichever technology we use, I think we have a lot at our disposal. But I think the indications and the lessons learned are that you have to choose your devices in the proper order, number one. And ultimately, it's dealing with calcium is all about device synergy. I mean, whether you do a NC, or you do a ROTA, NC, OPN, and thereafter also you sometimes may need IVL, as rightly pointed out sometimes. So it's all about how we prioritize and synergize our devices, especially in these complex calcified lesions. Acute coronary sometimes may not pose these many challenges, but sometimes dealing with the calcified acute thrombotic occlusions is also one of the challenges which we see in our practice, especially as we address more and more ACS conditions in the elderly population. So I think we just have to uh, be very discreet in our choice of devices. Thank you. Thank you very much.
Thank you, sir. Dr. Ledulak sir, anything from your side?
Yes, thank you, panelists, and thank you, Transumina team. It's OPN. It's very useful balloon for before and after stenting to preparation and after stenting to advanced stenting. It's very useful. And thank you once again, Transumina team and panelists and my colleague.
Thank you. Thank you, sir. So I think I would again like to take this opportunity to thank the entire faculty, especially the chairperson, Dr. Puneet Verma, sir, for taking out time from your busy schedule. I think Dr. Giacomo, thank you so much for joining us. And it was not looking like an international faculty joining us. It was, I think most of the questions were answered irrespective of the place that we are operating and doing angioplasty. I think the problems discussed were common to all, and it was pretty nicely explained. Especially, I think Dr. Ledulak explaining about protege, and I think in future, Translumina should try to look at OPN and DCB also, trying to get them used in the same case. I think, let's say in ISR, it can be an indication. So thank you all. I think it was a great session, and once again, thank you. We'll be signing off. Thank you so much. Thank you.
Thank you.
Thank you
Bye-bye.
very much.
Bye.
Goodbye.
Thank you and
Bye-bye.
thanks you.
Bye.
Bye.
Thank you. Good night.
Good
Thank you,
night.
Dr. No, thanks.